Top Med Talk.
Welcome to Top Med Talk. I'm Desiree Chappell, and we're coming to you from the last day of the 5th Collaborative Clinical Trials in Anesthesiology meeting here in Prato, Italy. I'm joined by our Editor-in-Chief, Monty Mythen. Hello, Monty.
Desiree, wow, what an amazing meeting. We just had another, let's call it a dose of clinical trials in the pipeline and some more results. So for those of you who've listened to this series, I'm apologising for repeating again, but we're here at some real estate owned by Monash University, and Monash University is in Melbourne in Australia, but we're in Prato in Italy, just north of Florence, where there is a gathering of around 100 of, let's call them the lead clinical trialists in the perioperative medicine space in the world. And we've been hearing late-breaking news, but also hearing about trials that are just getting going. And I think everyone is so inspired that, there's still, majority still here on another beautiful sunny day. And the networking and all the chatter that's going on about this, we just can't leave it in the room. We're talking about it at lunch, and it really has been a phenomenal meeting. So we've had the opportunity while we're here for Top Med Talk to speak with some of the presenters and talk to the people, some of the trialists that are doing some of the big stuff, and ones that have talked about some of their where they are in the process. There's been some information that's definitely embargoed we can't talk about, but we've also had some really great discussions about things that we can discuss. And so our next guest is someone that presented on Monday. It's Bruce Biccard. He's a professor and second chair in the Department of Anesthesia and Perioperative Medicine at Groote Schuur Hospital and the University of Cape Town in South Africa. Bruce, thank you so much for joining us.
Desiree and Monty, really thanks for the opportunity to talk about our work.
So Bruce, your presentation, I have to say, there was just amazing information that was given during these 3 days, but I think I was moved most by your presentation and the information that you were talking about in the ASOS-2 study that you have, that you're working on, and I'll let you explain all of that. But after your presentation, I looked at Monty and said, we have got to talk to Bruce and have him on Top Med Talk and hear more about what you're doing and share your efforts with the world. And so congratulations on everything that you've done. I think you are doing amazing things, and I just want to share that with our listeners. And so if you could just give us a little bit about your background, where you're from originally, and how you ended up in Cape Town, and then tell us a little bit about ASOS.
Well, I'm a Cape Townian. Did my medicine in Cape Town, my postgrad in Durban, South Africa. Then I was in Durban for a long time and moved back to Cape Town about 4 years ago. But really the work that we're going to talk about today is work by more than 1,000 people across Africa. They're essentially clinicians who are contributing to perioperative outcomes research in Africa.
So can you tell us specifically about the ASOS study? So we talked about ASOS-2, but if you want to take it back and tell us a little bit about your early work.
Well, the story goes back to 2012, I think, when Monty asked me to talk at a EPOM meeting. And at that meeting, I heard Rupert Pearce present USOS for the first time. And I'm a bit of a nerd, and I like research. And I thought that's something that's possible to do in a resource-limited environment. And so through that, Rupert shared his tools and his protocols. And we ran a USOS-type study in South Africa called SASOS. And then after that, with ASOS, I chatted with Rupert, and we thought we were going to give this a go across Africa, and that was ASOS.
Sorry to interrupt you, but for our listeners, can you break that down for us?
Sure, no problem. So the USOS, ASOS, ASOS, they're all surgical outcome studies. They're very pragmatic, just a tiny bit of data, and it's to get an idea of what's happening for patients who have surgery. And the beauty about them is that they cover a vast number of countries, so you can compare outcomes and you get a feel for what's happening in different environments. And really that was the beauty of doing it across Africa, because we could compare outcomes to what's happening globally.
What was the specific outcome that the ASOS-1 or ASOS-1 looked at?
So there were two outcomes. We looked at in-hospital mortality and in-hospital complications. And there was this big signal that In Africa, the patients are generally low-risk patients, but mortality is double that of the global average. And more importantly, complication rates is very similar to the global average, but they are twice as likely to die. And essentially, there is very few human resources, and we think this is a phenomenon called failure to rescue. The patients get sick, unfortunately, in the post-op period, but there are not enough people to keep an eye on them, and because of that, more people die.
I think if I'm right, Bruce, that one of the original observations about this idea of failure to rescue came from some data sets from the United States of America, where they also reported that disconnect between the incidence of complications and mortality. So in some places, although they may have similar complication rates, that they appeared to be doing something, stepping in some way to prevent that turning into death. Is that where it originally came from?
That's absolutely correct. And the response, the approaches people have taken are these early warning teams, where there's an alert from a patient who's looking terrible, and then a team comes and tries to salvage the patient, and often they go to high care wards or intensive care. But even though that's a beautiful concept, in fact, the evidence that they're making a big difference is questionable, and maybe we're getting to the patients too late. And that really comes to what ASOS-2 is, which what we want to do across Africa is to try and stop this failure to rescue. But as opposed to the patient putting his or her hand up and saying, look, I'm really in trouble, we want to move it forward. And so you identify the patient in the pre-op period and say, this looks like a high-risk patient, and watch that patient from the beginning. And then hopefully we can catch complications early and improve survival.
So practically, how are you going to tell us how you identify them beforehand, which I'm guessing is some sort of scoring system or gradation of severity. But then when it comes to going back to, and I'm guessing most patients will go back to the floor and a relatively unsupervised environment, what are you going to do to make people aware that they're in a different category?
So, thanks, Monty. So the beauty about the ASOS work is that we got really good data now, very simple data, and from that we built a risk stratification model, a really simple model. It's got 6 risk factors in it, and simple things like age and things about the severity and urgency of surgery, but it's actually a pretty powerful model for prediction. And so we're going to use that model to risk stratify patients in the pre-op period. And so it's very simple. It can be conducted before even the surgery starts, and it allows the team in theatre to say, this is a high-risk patient. What are we going to do about this? And that's the idea, is trying at the time of the surgical checklist is have the team discuss the patient and institute a plan for increased postoperative surveillance.
And Bruce, is the family and friends, are they key part of the support structure through Africa? And will they have some degree of knowledge and education about what to look for?
So this is a key part. So really what the group is trying to do, and it's a massive group of clinicians across Africa, and what we hope is that we'll find a generalizable intervention. So we've proposed 5 interventions, and you do as many of them as you can for as long as possible, of which one is have the patient's family stay with the patient at their bedside. So the 5 interventions are putting the patient in a high care ward, which often in Africa is not possible, increasing nursing observations, just putting the patient near the nurse's center, the nurse's station, so that they can see the patient all the time. Have the patient sit with the family sit with the patient, and lastly, we've got a high-risk sign which goes above the patient's bed. The philosophy is really just increasing contact time with the patient, and we think if you increase contact time, you're more likely to identify if things start to go wrong.
So improving communication as well with the team and creating that team. So a couple of things that you talked about during your presentation. One, about the resources that are in Africa. Well, first of all, how many studies are being conducted in Africa right now, and what are the resources like there?
Africa, unfortunately, the resources are very sparse. So what we saw in ASOS was, firstly, that from a human resource perspective for health care, there's a global recommended safe minimum of number of personnel to provide safe surgery, and Africa's, depending on the country, is about 20 to 50 times below that safe threshold. So the reality is people in Africa are working hard, and there's really not much elasticity in the system to do trials and those sort of things. So the reality is Africa does not really contribute to perioperative or surgical research, and the result is, I feel, interventions which are context sensitive to the African environment are not being identified. And that really has become the motivation for the ASOS network. The group feel like it's their responsibility to generate evidence to make health and outcomes better in Africa.
How is that? You said you have been creating a network, through the two different sites. How has that improved communication and do you think improved outcomes already so far in Africa?
It's certainly improved communications. So there are more than 1,000 of us now who work together. And we've collaborated a lot. I think we've got a very good idea of the picture of Africa, which is, you're twice as likely to die if you have surgery in Africa. If you're a mother and have a cesarean section, you're 50 times as likely to die. I mean, these are really strong signals of a need to do something. That's the first thing. And after ASOS, what we did is actually we conducted a survey on barriers and facilitators of research in Africa, and it's an extremely emotional type survey. There was qualitative data in it as well, where researchers and clinicians wrote free text, and in the free text, the real message that comes across is this is our problem, and we've got the capacity to take ownership for it and improve outcomes. So I think as a group, the group has got a very strong vision and philosophy.
One of the other slides that you showed, or that you were talking about, you showed kind of the number of hospitals participating in each one. Has that varied between the ASOS-1 and 2?
Yes, so when this whole ASOS network started, it was essentially cold calling across the continent and, asking people, please join us. We want to try and do something and introduce us to people. And so just on that cold calling and blind trust, we built up a network of 250 hospitals in 25 countries. But now, having had such success as a group, and now the group really is very strong and unified, and is growing quite quickly now. So for ASOS-2, we need 650 hospitals. At the moment, we've got about 380 participating hospitals, and we are over 30 countries now. And I think it's remarkable that some of the countries are in countries which are extremely resource limited, like Sierra Leone, Liberia, DRC. So I think that's testament to the individuals who are participating.
Bruce, I think one of the slides you showed about the countries that have joined in, I was trying to count quickly. It looked as though there are only about 6 or 7 who haven't been able to join in yet. And you reflected on some of the challenges those countries had. And I particularly noticed Zimbabwe because I think it's about 35, 36 years ago, just after Robert Mugabe, let's call it, took over at that stage. I was there as a medical student, and what an amazing country, what a beautiful country at the time. But I got the impression from you that you thought it would just be too difficult for them to join in at the moment.
Zimbabwe participated in ASOS-1, a brilliant, large contributing country to the trial and great clinicians and colleagues. Unfortunately, at the moment, I think it's politically very difficult, and that's why in that slide I couldn't show how many hospitals we had from Zimbabwe. I think it's very difficult for them at the moment. Unfortunately, I hope that things will improve and that they will be able to participate.
So there was another country, was it Namibia? Can you tell us about that one?
I think you're asking about Libya.
Oh, is it Libya?
Yeah.
Oh, sorry.
So in Libya, there's a civil war essentially carrying on, and it tells you again a lot about the people. So we have hospitals in Libya which are participating immaterial of what's happening at home, and so I imagine the conditions for our colleagues there must be really difficult, but they're also so committed that they will continue to participate immaterial of what's happening at home.
So, Bruce, the other thing you touched on briefly was resources, because no matter how collaborative people are, there's always a resource requirement somewhere. And I got the impression that you'd asked a lot of people and you hadn't necessarily broken through to the typical classical funders yet. They'll come, they'll listen, and they'll get there. But you have had some support, is that right?
My personal motto is I will prevail. And as a group, I think we all feel like that. So we have put some grant applications in, the sort of, as you point out, Monty, the traditional approach, and we've been unsuccessful so far. I am convinced, though, in the next couple of years we'll probably be successful, but at the moment we adopted the philosophy that we will just press on and do this. And so ASOS-2 ASOS-1 was essentially unfunded. So it was the goodwill of all the clinicians. ASOS-2 has started exactly the same. So the clinicians and the hospitals don't get any funding. And we have been fortunate, though, in that we got some funding from Bill and Melinda Gates, through an organization called Prato. The NGO do a lot of work in communications, and they hold a grant which deals with how can we make trials or health, how can we accelerate it using mobile technology or using technology. And they were very interested in what we're doing, because obviously across Africa you can't have a rigid tech approach. You can't just use the internet or just use a certain database. So we communicate on all sorts of platforms, WhatsApp and Viber and the net, and we use Google Translate and all sorts of things to be agile and innovative. So we got some funding like that. We're $110,000 US. Essentially what that pays for is our data administrator and 2 project officers who work 1 day a week. And so the rest across the continent, essentially, they're doing it for free.
If the presentations we've been hearing are correct, and I've no reason to doubt it, surgical morbidity mortality represents a massive disease burden, and it's up there on the scale with things that traditionally have been attracting quite a lot of support and funding, whether it be malaria, multi-resistant TB, or HIV. And it also sounds as though this is eminently, it may not be completely curable, but very curable by doing what we know already.
So you're right. There's a global surgery group in the UK, NIHR Global Surgery Unit, and they led an estimate of the global burden of mortality and placed surgery as a third leading cause or association with mortality globally. And that eclipses HIV, TB, and malaria combined, I think, the surgical outcomes. So yes, hugely important public health issue, improving surgical outcomes. We've done a really back-of-the-envelope type calculation for surgery in Africa, and we reckon if we're successful in this trial, it'd probably save 400,000 lives per annum.
Well, Bruce, we could sit here and talk all day about your experience. I have a ton more questions, but in the interest of time, I think the best thing that we can do is, the best thing that you could do for us is just share the ways in which us in the world of healthcare and actually the world can help you deliver what you are doing with ASOS and help with other studies. What can I do tomorrow to help you?
So thank you for this opportunity. I think there are 2 things people can do to help the network. I mean, the first is exactly what we're doing. It's create an exposure for the work. I think the work is super important. it is definitely going to make a difference to patient outcomes in Africa. And the second thing is funding. So funding is extremely difficult. Essentially, people are working in part of their day jobs. They're just doing this over and above. And any funding, to be honest, would make a massive difference. And to conduct trials in Africa, to be honest, bang for buck is really worth it. It's really inexpensive funding compared to funding that's needed for high-income country trials.
Have you thought about, or do you have any crowdfunding mechanism in place? Because the coffee chatter, the bar chatter here has been, that I think it would be very popular, very well received, very good and effective way of raising that money.
So, Monty, I've thought about it. I don't know how to do crowdfunding, but it is something that I think is probably a really good idea for this group. I would love some guidance, help, leadership. It would be great.
Well, hopefully we can work with you on that one, Ruth. We got you. We got your back. Well, again, thank you so much. I hope we can continue this conversation and hear more about the work that you and your network are doing, and look forward to talking to you soon. So thank you so much.
Yeah, thank you. It's been lovely to have this opportunity, and I would love to talk to you again in the future, and I'm sure you'd also love to talk to some of our other network members across Africa. Thank you.
One more question before we leave is that if people want to contact you or they want to contact the network or learn more about what you're doing, what are the best ways to do that?
So the easiest way is just to check out the website. So it's www.asos, that's ASOS.org.za. And ZA, asos.org.za. And on that website, you can see everything about the trial. There's contact details, the Twitter handles, all sorts of things. People can tweet me as well if they want to get the heads up. They can email me. It's bruce.biccard@uct.ac.za.
Top Med Talk.
Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.